Bismillahirrahmanirrahim. Dear students, the topic for today's discussion is a very important subject in pediatric, and that is the problems of hepatitis in children. You are very well aware that we broadly divide them into two main ways of presentation, acute and chronic. So today we will be talking about acute hepatitis in children. I am Professor Akmal from the Department of Pediatrics at Akhtar Said Medical College, Lahore. First of all, we should learn what are our main aims and objectives for this topic to be studied. First, we have to understand what is meant by the word acute hepatitis, what are the basic concepts and pathology and definition when you label someone as suffering from acute hepatitis. Now, this is a diverse etiologies. There can be viral, there can be toxic, there can be immune-mediated injuries. So all of them, they present as hepatitis, and it has certain common clinical features. Now, having done the clinical examination in the form of history taking and physical finding, we now proceed to the biochemical changes and the lab identification of first hepatitis and then its various types of acute hepatitis. Regarding the basic etiology of acute hepatitis, we should understand what is the normal course of events, how the disease begins, it progresses, and then improves over a couple of days, and what treatment should be offered during the phase of acute hepatitis in sick children. Very important role is to be played by the use of various vaccines and immunizations, both active and passive, in the management of acute hepatitis. And of course, this is not a disease of just one individual coming to a hospital, but again, this disease has a very important from the community point of view. It affects large number of children, causes a lot of morbidity and mortality, and how we can overcome that. So, acute hepatitis is defined as a disease causing inflammation of liver. The liver cells are inflamed, having all the features of inflammation like decreased functioning, like increase in size, congestion, edema, and poor and disturbed liver functioning. Now, if the disease process is acute in onset and settles down quickly, usually within a few weeks' time, is labeled as acute hepatitis. The duration is maximally assigned as less than 6 months, because most patients have already recovered and they can be labeled as acute hepatitis by the 6-month arbitrary cutoff value. Now, what causes acute hepatitis? It can be multiple etiologies. You can have a number of viruses which are called hepatotropic viruses, which mean like hepatitis A, B, C, E, they are all very important. There are other viruses like cytomegalovirus, which it definitely invades the liver tissue. There are problems of Epstein-Barr virus. There are patients with herpes virus and many others, which primarily affect the liver and the liver parenchyma and cause liver cell malfunctioning. We have a number of drugs which also cause acute hepatitis. Important one being antituberculous, anti-epileptic, and certain antineoplastic drugs, which are hepatotoxic and they induce typical features of liver cell injury. Then we have a number of chemicals and the toxin which induce hepatitis. There are certain food poisons like aflatoxin, mushrooms. We have certain chemical in the industry. We have certain chemicals, especially say anesthesia gases. They can cause hepatitis. So many chemicals, they affect the liver tissue and produce typical features of liver disease. We have a number of metabolic diseases, metabolic causes which affect the liver parenchyma. Then the patient, if he develops cholestasis, that is decreased biliary flow, then patient develops features of acute hepatitis. And then we have hepatitis as a result of immune mediated phenomena, like antibodies are synthesized and they cause autoimmune phenomena to the liver tissue. So that is feature of the immune hepatitis. You must have learned liver function tests at the time of the subject of physiology and then in pathology, but let's quickly review it because these are basic to understand the biochemical changes during liver cell damage or hepatitis. We broadly divide them into a number of things like that. There are tests of liver damage. They indicate that there is hepatocellular damage and the release of these enzymes in the circulation which we can detect. Important ones are the SGPT, now labeled as alanine aminotransferase, SGOT, now labeled as aspartate aminotransferase, and lactate dehydrogenase. These levels, their levels definitely indicate that there is liver cell damage going on in this patient. We have certain liver function tests labeled as metabolic or excretory function are being tested by important level of serum bilirubin, total, direct, and indirect, because in direct liver cell damage, these are affected. The total is raised, the direct is raised. And same happens with the features of the cholestasis, in which these are all raised. Serum ammonia levels. You know that ammonia is produced from the metabolism of the amino acids, and the ammonia is then converted into urea. So raised ammonia level is an important sign of liver cell dysfunctioning. There are tests indicating that the bile flow is not normal, is interrupted, is blocked. There is cholestasis, and this is revealed by features of raised alkaline phosphatase level, raised gamma glutamyl transpeptidase level, GGT, and raised 5-nucleotidase levels. They are raised in patients having either anatomical or functional biliary blood flow obstruction. Then there are liver function tests indicating the poor or the disturbed synthetic function of liver, like albumin level and like prothrombin level, which is basically a clotting test, but again is markedly deranged in liver malfunctioning. So coming to viral hepatitis A, the previous name is being infective hepatitis. So this is caused by an RNA virus, just one serotype, widely prevalent, and it is spread by fecal oral route. That is, either it is foodborne or waterborne. The contaminated food and the contaminated water intake by the recipient, that leads to exposure, and a full-blown picture of hepatitis A follows after the incubation period. Now, this is a self-limiting disease which has its onset after the incubation period, and then it becomes a clinical disease, and then it settles down in vast majority of cases. It doesn't lead to a chronic hepatitis. It settles down within a period of 4 to 6 weeks time. Sometime we see a relapse, But again, the whole process is finished within 6 months' time. Less than 1% of cases, the disease becomes very important, that is causing acute liver failure, which is the phenomenon of the acute fulminant hepatitis that might end up in death of the patient. The incubation period is usually between 2 to 6 weeks, 15 to 40 days. Very common in children in developing country. It has been estimated that more than 90% of children below 5 years have been exposed, have been infected, and they are revealed by the presence of antibodies in their blood. And again, more than 90% of cases, they are asymptomatic. These asymptomatic cases, patient behave normally without any particular signs toward hepatitis, and the patient are totally become unnoticed. And again, majority of these cases, they're anecdotic. They just develop mild symptoms of some nausea, some vomiting, mild 1 or 2 pain, abdomen, diarrhea, and then fine. They don't develop obvious discoloration of the eyes and the sclera and the urine to become noticeable. So again, they remain unnoticed. This is the distribution geographically for hepatitis A throughout the world. You see the red color shows the areas of the globe which are the disease widely prevalent. This includes the South America, this includes the whole of Africa, this includes the Indo-Pak, Arabian, and the Southeast Asia. So these are highly prevalent areas where the disease of hepatitis A is widely prevalent. Other areas are relatively spared, like North America, like Europe, like Russia and other areas, and Australia. So the clinical course is again very typically described as in 3 phases. One thing is the prodromal phase, which lasts from 3 to 7 days. Patient has features of fever, lethargy, fatigue, poor appetite, nausea, vomiting, pain abdomen. Very vague symptoms, nothing specific for the liver. But again, in the next phase, soon the parents found that baby is passing dark colored urine. His skin, mucous membrane are all yellow. His eyes are yellow. He is passing pale stools. He has got, on examination reveals, an enlarged liver in the right hypochondrium, which is tender, and patient might complain of itching. This phase is followed by the recovery phase between 2 to 6 weeks time, in which patient gradually resumes his normal appetite. He asks for typical food that he was previously refusing. His yellow discoloration decreases, eyes are clear, jaundice from the urine is relatively less yellow, and the liver size regresses. So that is the typical course of acute hepatitis A. Now this is again a diagram of the various features of acute hepatitis A. You can all find out that the red mark shows the presence of the virus in the feces, the fecal hepatitis A. Before the patient develops symptoms, patient is passing virus in the stool and continues to doing so for the first 1 to 1.5 months. This is followed by raised liver enzyme level and the symptomology. The patient becomes jaundiced. Usually the duration is just 1 to 2 months time. The patient the liver function test usually come back to normal within 1 to 2 months time, while IgM antibody, they are synthesized in the body from the beginning of the clinical phase and then usually have come down to very, very low level around 6 months to 12 months time. However, IgG antibodies indicate previous infection. They are coming in the blood around 2 to 3 months of disease process and then continues lifelong. So one can always detect the patient had a previous history of hepatitis A exposure or not. Outcome, we all understand that in most cases this is a mild disease. Recovery is very prompt in more than 90%, 99% cases. There can be a small clinical relapse. That patient may become somewhat jaundiced or somewhat having features of GIT upset in the next 1 to 2 weeks time, but again it recovers. They don't have to go to hospitalized or admit. They don't require any liver transplant therapy. However, some unfortunate cases reach the stage of fulminant hepatitis, but that happens in just 0.35% cases. How do we manage them? There is no cure and there is no specific treatment for this viral illness because we don't have a specific antiviral drug. But do we need to hospitalize? No. All patients do not need hospitalization because there's a risk of spread to non-infected person inside the hospital indoors. All what we have to do is to prevent the state of dehydration, give them IV fluids, give them simple advice of home treatment like bed rest. One must be aware that there are certain danger signs. There's a red flag sign which, if present in any patient, should be a very important indication for admission. Like the patient becomes drowsy, patient develops progressive edema, patient starts bleeding, patient has features of hepatic failure, so then that patient should immediately be hospitalized and worked up accordingly. The principles of home treatment are very simple, like bed rest, like disposal of excreta hygienically, like strict, thorough, repeated hand washing with soap and water. There are no dietary restriction, simple, bland, soft diet, easy to digest is all what the patient requires. Do not use any hepatotoxic drugs. Important ones are like paracetamol, which should be avoided. And there is no role of any liver tonic. There are so many available in the market, but they do not affect the natural course of illness, which is self-limiting and resolving. Prevention is again to be stressed on the parents, patient, and among the doctor community as well, that clean drinking water is very basic to prevent it, like proper disposal of sewage hygienically. Patients should be educated about basic principles of education and hygiene. And of course, we understand that there are effective vaccination both actively and passively. They are available, but they're still not part of EPI. So vaccination, we must know that there is a vaccine to prevent hepatitis A, and is not part of EPI, but then again, for those patients who are living in hyperendemic areas and those who are visitors from the developed world here, they should be vaccinated before coming to these areas. This vaccine is offered after the age of 1 year. 2 doses are to be given, 6 months to 1 year apart. And if the patient has come in contact with another patient of acute hepatitis, then some of them they can be offered like immunoglobulins for passive immunity. Now this immunoglobulins are indicated for post-exposure contacts, say in a daycare center, where there are so many children kept together for a couple of hours, and one of them develops hepatitis. So immune serum globulin can be given to those cases which are candidate for passive immunization, 0.15 ml to be given deep intramuscular once. It will give them a short-lived immunity and prevent the new episode. Coming to hepatitis B virus, again a disease which was previously labeled as serum hepatitis, but now labeled by the hepatitis B virus. In all such cases, that diagram shows how it looks like. Now that table just compares the important hepatitis viruses like hepatitis A, B, C, D, and E viruses. In a nutshell, it tells you that hepatitis A is RNA, B is DNA, hepatitis C is RNA, and hepatitis E is again RNA. The size is given for comparison, keeping in mind that hepatitis B virus has got a larger molecule, larger virus size. The transmission is again mentioned that for hepatitis A, fecal-oral, hepatitis A and E are fecal-oral, while hepatitis B, C, and D, they are mostly parental, sexual, and perinatal. Now, A and E, they do not have chronic infectivity. They clear within a period of less than 6 months, while B, C, and D, they many a time they continue as a chronic infection, as chronic hepatitis. And sometime, in very unfortunate cases, like hepatitis E and A and B, they may end up as fulminant hepatitis. Now, this is a structure of hepatitis B, a sketch showing that the center is occupied by DNA polymerase, surrounded by shells of hepatitis B, surface antigen, outermost, then we have the core antigen, and then we have the E antigen. So these are three very important antigens which have a role to play in the diagnosis and the progression of disease. We have got in the center is occupied by DNA polymerase, surrounded by coatings of three different antigens: surface antigen, core antigen, and E antigen. In children, a very important role is to be played by perinatal transmission. There is mother having hepatitis B carrier. She is hepatitis B surface antigen positive. So when she conceives and delivers the baby, then there is a more than 90% chance of infecting her own baby, and that baby will not manifest jaundice, he will become a carrier. So there is a 90% chance in that situation. So that means that children have a very high chance to develop hepatitis B carrier state after getting infection in a perinatal way. There is also a horizontal transmission, that is from the one patient to the next host. So hepatitis B usually clears, but if there is a horizontal transmission, like child to child, through contaminated needles, sexual contact, healthcare workers, blood transfusion, then around 6 to 10% chance that if someone gets infected over the age of 5 years, he becomes chronically infected. So we have learned that hepatitis B spreads by parenteral route, that is through the blood and the blood products, and through the perinatal route at the time of birth. Incubation period is quite longer. That is something like 50 to 150 days to 180 days. There is a prodromal phase of 2 to 3 weeks, followed by icteric phase. Patient becomes deeply jaundiced. It may last for 4 weeks. Patient has got jaundice and all features of hepatitis, but additional features are that he has extra hepatic feature like pain in the joints, joint swelling, and a skin rash. These sometimes can be differentiating it from hepatitis A, and then followed by the recovery phase or convalescent phase. Very few patients remains free of jaundice, and some patients are unfortunate, less than 1% who may develop acute liver failure. Once we investigate these children with hepatitis B, you will find that the liver function test shows raised bilirubin, raised ALT, raised AST. They have got a positive hepatitis B surface antigen, they've got a positive hepatitis B DNA, and they have got a positive hepatitis B E antigen. And again, this tells you the role of the interplay of antigens and the antibody once a patient is infected. Because hepatitis B virus infection soon leads to formation of various antibodies, like antibody against hepatitis B E antigen, antibody against B surface antigen, antibody against hepatitis B core antigen. And that is, we can interpret these antigens and the antibody according to this graph. It has been estimated that something like 4.5 to 9.5% pregnant mothers during childbearing age have been exposed to hepatitis B surface antigen. So this is a very high figure. That shows the importance of perinatal transmission in children. The mothers are carrier, they are asymptomatic. So once they will deliver, they will transfer this virus to their babies. So that is, it's become mandatory that every mother during pregnancy should have her hepatitis B surface antigen checked in a correct way. We understand that there is almost more than 90% chance of perinatal transmission if the mother is hepatitis B surface antigen positive, she is a carrier. Again, if the mother has got hepatitis B antigen positive, first she was HBsAg positive, now she has got hepatitis B E antigen positive. In that case, more than 90% transmission has been noted from mother to baby. So this means that when such a baby is delivered, we must immediately vaccinate the baby with hepatitis B vaccination within first 24 to 48 hours as soon as possible. The vaccines are given at 0, 1 month, 2 months, and 12 months. And in addition, we should give hepatitis B immunoglobulin 0.5 ml intramuscular to these babies soon after birth, within 12 hours of birth. So that we are giving active immunity and passive immunity both. But again, both of them are not given on the same site, but again, we use other side. They're not on the same arm or the thigh, but use on the one side use vaccine, on the other side use the immunoglobulin. In that case, we check the baby's status at 9 months of age. Unfortunately, with this protocol is strictly followed, then majority of babies are prevented. They don't become hepatitis B and surface antigen positive, but they develop active immunity. And very few cases ultimately still develop hepatitis B carrier state. So, if for general population, hepatitis B can be prevented by, number one, we must vaccinate all babies as per EPI schedule, which is now given as 6, 10, and 14 weeks. Hepatitis B is essentially included in the pentavalent vaccine in the EPI program. Now, there is every stress from every WHO authority, UNICEF authority, all advocate that hepatitis B should have a birth dose of hepatitis B to all children between 0 to 3 days of life to prevent maternal fetal transmission. Because you see that previously we were giving at 6 weeks. So there is a window period of 6 weeks in which babies can become infected. So there is always an indication and advocacy for using a birth dose of hepatitis B along with BCG. Number 3, we must screen all pregnant mothers. Mandatory. Next, we must screen all blood transfusion bags and all blood products because that has been involved as a major source of transmission. Then we must have a safe IV intramuscular routes of parenteral drug therapy. It should not be taken as lightly because whenever we use a needle, we reuse it, they double prick, and again the patients are unnecessarily exposed to hepatitis B. Similarly, injuries because of needle pricks, circumcision, cord cutting, ear pricks, shaving, tattooing, narcotic addicts who share the needles, all of them are very important candidates who get hepatitis B. And of course, there is a universal precaution for all healthcare workers that whenever they come in contact with all body fluid, they must wear gloves and they must throw away clean hand washing repeatedly. We have done that because we have said that the vaccine is there. It is a recombinant vaccine. We give it 0.5 ml for the babies at birth, then at 6 weeks, then at 6 months, and then 1 year. And for those babies who are already born to hepatitis B surface antigen positive mother, they need vaccine as well as they need immunoglobulin IgM 0.5 ml within 12 hours of birth, but at different site. These mothers, they can breastfeed their children. There is not a contraindication for breastfeeding. Now, that is how we interpret different reports that we happen to see in these patients. If you find the importance of antibodies against hepatitis B core antigen is that this indicates acute infection and this indicates chronic infection. Antigen like hepatitis B E antigen, this indicates very high infectivity to others. If there is hepatitis B E antibody, this indicates patient is not, that is, the source of infection, the original patient is not very infected. If there is a hepatitis B surface antigen positive, this implies that this more than 6 months, this indicates chronic infection in the patient, is a carrier. And if there is anti-hepatitis B antibody, this indicates that patient has received adequate vaccination in the past. And for hepatitis B DNA viral load, this indicates whether the patient has got acute viral infection or not. Coming to hepatitis C infection, the chances of maternal neonatal transmission is 5% compared to the hepatitis B, which is very high. Again, the vaccine is mostly spread by parenteral route, and both methods of delivery like normal delivery and C-section, they are involved in this transmission, and the breastfeeding is not contraindicated. The mother can definitely continue breastfeeding because there is not an increased risk of transmission of hepatitis C from mother to baby. This may present in the patient as acute hepatitis, but the duration of the illness is less than 6 months with positive serology. But the main importance is that 75% of infected patients, they develop chronic hepatitis. Now, this chronic hepatitis may be totally asymptomatic, and after a period of decades, 20-year, 30-year, 40-year, patient may come up as having cirrhosis or hepatocellular carcinoma, which are long-term sequelae. Hepatitis E, again, this is important in children. It is an RNA virus spread through the fecal-oral route by contaminated water and food. It usually resembles hepatitis A. That is, it presents as prodromal phase, icteric phase, convalescent phase, like acute hepatitis, usually between 4 to 6 weeks time, 4 to 8 weeks time. But however, the importance is that it may present as having epidemics in large cities and towns. Usually, the community water supply has been infected, and that involves a large community in the form of hepatitis. Now, this is a mild disease in children, except that during pregnancy, if the women are infected, it may end up as having a fatal outcome. This is diagnosed by antibodies against hepatitis E antigen as IgM, and of course, there is not a chronic disease, not a chronic carrier. Finally, we know that there are a number of drugs which can induce hepatitis, which can be intentional, homicidal, suicidal. Especially important ones are the anti-tuberculous drugs like INH, rifampicin, PZI, anti-epileptic drugs like valproate, like phenytoin, common drug like paracetamol, like anabolic steroids, like methotrexate, used in a number of conditions like nephrotic syndrome, like leukemia, lymphomas. So many anti-cancer drugs, they involve the liver. So the important lesson is that we should always suspect the role to be played by drugs in all jaundice children. It is frequently overlooked and missed. So you must monitor the liver function test. Immediately stop the drug should be the first treatment remedy. If the liver function is raised, stop the drug immediately. Give them supportive therapy, and patient gradually, the liver start having a back to normal function. Sometimes we use for paracetamol poisoning a typical antidote called N-acetylcysteine in very selected cases. This is the last slide. These young babies, they were born healthy, free of any viral illnesses. So it is our primary duty to keep these babies free of hepatitis and its various etiologies. Thank you very much for your kind listening.